We are on live. Thank you.
Honorable Chair of this session, dear speaker, dear participant, and other panelists, Assalamu alaikum. This is Dr. Sharmeen Abbasi, Associate Professor of OBGYN and Associate Faculty of Planetary Health Academia. Welcome you all to a very exciting session that is the pre-existing cardiac disease with pregnancy. Pre-existing heart disease is a heart problem all of we know, and that had before pregnancy. Sometimes it may be congenital, but it may also include things that anyone develop later in life. So even if heart disease does not cause any symptoms or has not affected life, it may cause issues during pregnancy. This is because of changes in body that happens when pregnancy starts. And sometimes some women even does not know that they have a pre-existing heart disease until the stresses of pregnancy reveals the problem. So today we will discuss on it, because in Bangladesh, there are many questions regarding this. How can we manage this patient, preconceptional counseling and management for this sort of patient, multidisciplinary team approaches for this sort of patient. So how much ready we are regarding the obstetrician point of view and also the collaboration and multidisciplinary team approaches. So it is our great pleasure that today as a chair, we have Professor Farhana Dawan Madam with us. Professor Farhana Dawan Madam is a great academician of our country, and at the same time, she is the now President of Obstetrical and Gynecological Society of Bangladesh, Deputy Secretary General of the SAFOG, and the Professor of Department of OBGYN Ibn Sina Medical College Hospital. Please welcome Madam to our session. And there are many series program will happen with pregnancy with cardiac disease. And today we solely discuss on management of pregnancy with pre-existing cardiac condition. As a speaker, we have Dr. Rehana Zaman, consultant obstetrician and gynecologist, Nobles Hospital, East Loughman, UK, and faculty lead of OBGYN of Planetary Health Academia. And we have three renowned panelists of today, which we'll discuss and introduce by Dr. Mashrafi Ahmed. Dr. Mashrafi Ahmed, also the co-moderator of today's session, and he is a renowned cardiologist, clinical assistant professor, University of Massachusetts, and interventional cardiologist, Pioneer Valley Cardiology Associate of USA. So please welcome Dr. Mashrafi Ahmed among us. And first of all, I would like to invite Dr. Rehana Yasmin Zaman. Dr. Rehana Yasmin Zaman firstly will put light on pregnancy and that is related with the pre-existing cardiac conditions and how can we should address this. This will be discussed by Dr. Rehana Zaman. Please welcome Dr. Rehana. Appa. Rehana.
Thank you. Thank you, Sharmeen. Thank you for introducing me. So in this session, I'm going to just discuss the overview of the cardiac disease in pregnancy. And then we got three cardiologists and experienced cardiologists. I'm sure they will then share their experiences, and we're going to go through three cases. And at the end of the session, Sharmeen is also going to we'll do some MCQs and see what is the outcome from that, and we take it from there. Thank you, everyone. So as Sharmeen introduced, I'm one of the Obs and Gynae consultant, and I'm the clinical lead for Isle of Man Women's Health. I'm also the lead for Planetary Health Academia. I have been working with RCOG on their global health project for more than 10 years now. So it's my privilege to share my experience with you all. Sorry. So the spectrum of cardiac disease varies. It's a wide range how it affects the pregnant woman in the world. It ranges from 0.2 to 4%. But maternal mortality with the pregnant woman with CVD is about 1%. In Western countries, the cardiovascular disease is one of the the highest mortality rate, major causes of the maternal mortality as the indirect cause outside the direct obstetric cause. Now, congenital heart disease is predominant type of cardiovascular disease in the first world countries. Rheumatic heart disease still an important cause of morbidity and mortality in low income and middle income countries. Ischemic heart disease is actually rising because now more older women are giving birth. There is a pandemic of obesity, smoking, hypertension, high cholesterol, and also diabetes is increasing. So as a consequence or as a complication of obesity, smoking, hypertension, diabetes, we're seeing more and more ladies actually suffering from ischemic heart disease. And when they become pregnant, that becomes a big problem. There are not that mortality of women with the cardiac disease overall in low, but some of the high-risk conditions like Eisenmenger syndrome, pulmonary hypertension, severe systemic ventricular dysfunction, Marfan syndrome are the major causes of cardiac mortalities. So what can we do? We know that pregnancy itself alters the it becomes a demanding situation for women's body because the cardiovascular change, there is change in the glucose metabolism, cholesterol, coagulation, hemostasis, everything puts pressure. And when someone has got cardiac disease already, then it makes even more complication. We all know, we're just going to quickly, the physiological changes, the plasma volume goes up at least 40% above the baseline around 32 weeks. That's the highest peak, and 30 to 50% increase in the cardiac output. Early pregnancy, the stroke volume goes up and the heart rate goes up at the end of towards the end, third trimester. And systemic blood pressure drops in the early pregnancy because of the vasodilation. There's heart size also increased by 30%, increased concentration of coagulation factor, and so it increases risk of thromboembolism, decreased venous return because of the gravid uterus and the enlarging uterus putting pressure on the vena cava. And also, if someone on a medication, because of all these changes in the volume and plasma, that affects that they need the adjustment of the medication. Now, as I have already said, there is a figure, as you can see, plasma volume goes by 40%, cardiac output goes by 30 to 50%, cardiac output during delivery and postpartum also goes up. Only thing drops is the vascular systemic vascular resistant, and that also because of the increase in the plasma volume, there is physiological anemia, which causes a little bit more burden. There is transient left ventricular dilatation, and also pregnancy is a hypercoagulable state. I think as a nature, just to stop bleeding during pregnancy, God created us like that, so it becomes hypercoagulable. Weeks to months of it takes weeks and sometimes months for the cardiac output and the SVR to come back to baseline. And these graphs also nicely showing that during the first trimester, if you can see, the cardiac output towards the end of the first trimester, it starts going up and up. And then just towards the end or just before it finishes the second trimester, it plateaus. And then just after delivery, and then it's started coming down and normalizes. If you look at the blood pressure with the red line, blood pressure drops towards the first trimester and then starts going up, picks up around the time of delivery. That's why many of the people, pregnant ladies, will actually first time present with the hypertension or pregnancy-induced hypertension around the end of the third trimester. And then it comes down and it slowly then goes back or normalizes. Same thing with the heart rate. It goes up towards the third trimester. Suddenly it picks up really around the time of the third trimester or the delivery time, and then starts coming down again and then slowly normalizes. But the systemic vascular resistance, it drops dramatically up to second trimester, and then it plateaus and then slowly goes up and then normalizes after delivery. Now, how do we estimate the maternal risk? So there are lots of risk assessment checklists, but the modified WHO classification of maternal cardiovascular risk is the one which is widely used. So it categorized into 4 classes. I'm sure my colleagues will discuss that in details more. So like in pregnancy, the WHO one, stage 1 is uncomplicated, small or mild pulmonary stenosis, patent ductus arteriosus, mitral valve prolapse. If they had successful repair of any lesions, they're also in this category. And if they remain symptomatic and stable, they then continues to be there in group 1. There is also atrial or ventricular ectopic beats, which is quite common. Supraventricular tachycardia, we see quite a lot in pregnancy as well. Then comes to, there is some overlap between group 2 and 3. If they are otherwise well and uncomplicated, they belongs to 2, but there is, as I said, if they becomes asymptomatic, then goes to 3. But my cardiac colleagues can tell me more details about it. They are unoperated atrial or ventricular septal defect, repaired tetralogy of Fallot, or most of the arrhythmias are in this group if they're well and their conditions are under control. So there is, again, WHO 2 and 3, depending on the individual. If they becomes a little bit more symptomatic, they goes to 3. So there is overlap. My understanding is there is overlap between 2 and 3. So they're like mild left ventricular impairment, hypertrophic cardiomyopathy, valvular heart disease not considered in 1 or 4, so who are in between. So either they are not symptomatic or they are not that unwell, so they are not in the 4, so they are in the middle. Marfan syndromes with aortic dilatation when the aorta is less than 45 millimeter and repaired coarctation of the aorta. And then definite group 3 are people who had mechanical valve. They have systemic right ventricular problems, Fontan circulations, cyanotic heart disease unrepaired, other complex congenital heart disease. And when the Marfan syndrome aortic dilatation is 40 to 45 or 45 to 50 associated with bicuspid aortic valve. Group 4, they are the one pregnancy is contraindicated. And because of the risk of significant morbidity and mortality, like pulmonary arterial hypertension of any cause, severe systemic ventricular dysfunction, previous peripartum cardiomyopathy with any residual impairment of the left ventricular function, severe mitral stenosis, severe symptomatic aortic stenosis, Marfan syndrome with aorta dilated more than 45 or more than 50 when it is associated with bicuspid aortic valve. And now with the, sorry, I don't know whether you can see the screen is quite small, but depending on which stage they belongs to, the protocol which we follow in the UK, if they're in the group 1, then once or twice, so we will discuss their case with the MDT, but most of the time they will be seen by the MDT or discuss in the MDT once or twice, and we will make a plan, and the delivery will be in the local hospital. If they are in the group 2, then the follow-up during pregnancy, every trimester, we're going to discuss in the MDT. They will be in the local hospital and they will also deliver in the local hospital. If they belongs to 2 or 3, then follow up bi-monthly, sort of every 2 weeks, we discussed with the expert center. Sometimes they goes to the expert center or tertiary center to have some investigation and follow-up, and they will be delivering in the tertiary center. Same with the group, definite group 3 as well. But group 4, who are very high risk, pregnancy is not recommended. But in case someone is unplanned pregnancy, they get pregnant, what you do? You offer them termination of pregnancy or discuss that, but it's at the end of the day, it's their choice. So if they take the risk, they will have a thorough counseling jointly by the obstetrician, cardiologist, anesthetist as a group. And if they still wants to continue the pregnancy, then they will be all the time in the tertiary center until they delivers, and even after delivery, they will be there for a while until they're stable to be discharged from the hospital. Now, these are the, sorry, these are the, this is the model which has been sort of followed in Botswana, which is one of the low and sort of groups belongs to low middle income countries. So what they do, if the patients are in the classification of 1, they will discuss with the tertiary medical facility. They will have blood pressure check, ECG, assess for MARMARs and everything. If it is normal, they will be remained with the local maternity services. If they have any of the tests are abnormal, then they will be referred to a tertiary center for joint obstetric, cardiac, anesthetics, maternal team or heart team. But that will be not an urgent referral. That will be like a non-urgent, means they can take time to go there. If there is any of the ladies belongs to classification 2, they will also have a non-urgent referral to this heart team. But modified WHO 3 and 4, they will go urgently. They will be referred urgently, and then they will be seen by them. Now, because in Africa there is also HIV is quite prevalent, so they will HIV specialist also will be there. And they will be having their regular checkup there. They will deliver there. Even after delivery, they will be there. So this is the model they followed in Botswana, so which is one of the low and middle income country. In UK, what we do, we try to do a preconception counseling, because many of the young ladies who have got pre-existing cardiac condition, who are under the pediatric cardiologist, when they reaches the stage that they are now adults, they will be actually referred to the adult cardiologist, and the adult cardiologist will discuss with them. They prepare them saying that, okay, when you get pregnant, these are the complications can happen, and these are the things we need to do. So they will, when they will be aware. So it's actually patients' awareness, patients' families' awareness. When they become pregnant, they will inform the cardiologist, and then we get informed. So this is one way of knowing about this patient. Other way is the GP. Some of the GPs are quite good. They have been looking, if they belongs to group 1 or 2 who are doing well, the GP will actually write to us with a detail saying that this she had these cardiac problems and she had these treatments, and so these are the needed to be done. So this is how we come to know. But we because of the loss of migrant populations, it's not that we don't have any surprises. We also have surprises. But at the pre-conception counseling, what are the things we like to do? Assess the situation of their cardiac condition. So have a detailed history, obstetric history, any other comorbidities, whether they got diabetes, they got hypertension, assessment of the current functional status, do an echo, do an ECG, and we discuss with the cardiologist whether they need the cardiopulmonary exercise testing or cardiac MRI. It depends on what they have got as a condition. So basically, preconception counseling is mainly for optimizing the condition, their medical, surgical, or any other intervention needed. They maybe that before they gets pregnant, that needs to be done. They get advised by the dietitian about life and even the physios, lifestyle modification, smoking cessation, folic acid, vitamin D supplements, and adjustment of the medication. They also need to know that in pregnancy, there will be physiological changes, volume changes. So they may have to have they need to inform the team so the medication dose can be adjusted. So these are the essential information need to be provided in the preconception counseling. Now, if someone is the group belongs to the group 4 and they need to have the termination of the pregnancy, there is a rapid access to the services done. There also is a multidisciplinary clear because they are high risk. So in case they need to have a surgical termination, then as anesthetists, cardiologists, everyone's input is needed. At the same time, even though if maybe it's unplanned or even is planned, and they needed to have the termination, they need a huge amount of counseling and psychological support, because it's not a very easy thing for many of the ladies. If by chance someone has got a miscarried the pregnancy, that also need to be managed by multidisciplinary team to see where is the best place for them to have any treatment. If it is complete miscarriage is fine, but if it is incomplete, they need surgical evacuation, medical management, or manual vacuum aspiration. Normally, if they're less than 9 weeks, we try to do them in a surgical theater, but not necessarily having general anesthesia. Sometimes sedation, we do it in the presence of anesthetist and the cardiology team. And then we also, if they're quite complicated cardiac situation, we always book a bed in the ITU or ICU. This is the, I don't know whether you can see, this is the stages of pregnancy. So when any ladies with cardiac disease during pregnancy, they get first appointment with the midwives around 6 to 7 weeks, or as soon as they know they're pregnant. And then they have baseline investigation, review the risk factor, functional status, as I've already discussed, medication of the cardiac disease, whether they have any obstetric cardiac risk. All the information, advice, support will be thoroughly discussed in that meeting. So the midwives, normally when they get a referral, they will inform the obstetric team. So then we arrange the cardiology team, everyone to be involved. By 10 weeks, we do dating scan. So we'll confirm the viability of the pregnancy. We will discuss again more same information, education, advice, how cardiac disease will affect her pregnancy, delivery, early parenting, such as even breastfeeding and initial care of the baby. By 22 weeks, we offer fetal echo to women with structural congenital heart disease, because if the mom has got a congenital heart disease, the fetus is quite high risk of having that as well. Now, depending on their status, which group they belongs to, 2, 3, or 4, then they will frequency of time they will be seen by the MDT, which I've already explained in another slide. Interpartum care always has to be by the senior obstetrician with the multidisciplinary team. So if we are inducing someone for obstetric reasons or cardiac reasons, we plan it normally at the starting of the week in discussion with the whole team, and what is the suitable place and which date and all this thing, because even in the weekend in Western countries, it can be difficult, depends on where you are. If you're a tertiary hospital, that's fine. If you're a district general hospital, things can be quite difficult during the weekend and holiday time. So early involvement of the obstetric anesthetist, preferably antenatally, fluid balance needs to be monitored very well, especially with the moderate and high risk cases, maintenance of the blood pressure and maintenance of volume, and like in needed, then they will have an arterial line as well. Same thing with the peripartum time. Oxytocin is preferred over to argometrin, because of the argometrin can shoot up the blood pressure. In severe heart disease, what we do, we instead of a normal regime of, we normally give like 20 units of syntocinon in 500 mL, that for normal ladies. But in this situation, to reduce the volume, we just do 5 units in 20 mL over 20 minutes of time. So it's a slow, low dose. And if we need to shorten their active second stage, then we help them with assisted vaginal delivery. If someone is in preterm labor, as a choice of tocolysis is atosiban rather than calcium channel blocker like nifedipine, because it can severely compromise the cardiac function. In the postnatal period, also they need intensive monitoring, because the risk of decompensation is quite high that time. So if depends on which group they are, if they belongs to 2, complicated 2 or 3 or even 4, they will be in the obstetric HDU or level 3 ICU. strict full balance because the heart failure is the particular concern here. HDO chart needs to be monitored, and where appropriate, thromboprophylaxis needed to be done as well. So regarding peripartum care, we don't use routinely antibiotic prophylaxis in UK, but we'll have low threshold for antibiotic prophylaxis if needed. If you suspect choriamnitis or even mom have pyrexia in labor or something, then we will give it. Otherwise, it's not a routine. For postpartum hemorrhage, for the uterine hypotonia, mechanical methods like bimanual compression, Billin suture is the preferred rather than medications. But if needed, misoprostol is preferred on over the carboprost or prostaglandin E2. It has less active effects. And also, that thing I wanted to mention that tranexamic acid, if they're bleeding and then we think there can be risk of thromboembolism, but it's better to, it's better to actually control the PPH that time, and then we can actually give them anticoagulation. We discussed that with the hematologist, but preferred thing to give tranexamic acid to stop the PPH in conjunction with other methods rather than not giving it because of the risk of thromboembolism. Now, as you can see in this slide, so this is the last slide, that this is the circle of the pregnancy with a cardiac disease. So the cardiac obstetric or the heart team, which there is obstetrician, cardiologist, maternal fetal medicine, genetist, anesthesiologist, pharmacist, and the midwife or nurse. So they are involved in the pregnancy counseling. Then again, during the monitoring, during pregnancy, then during the delivery. Regarding the delivery, vaginal birth versus cesarean section, cesarean section is not preferred if it is obstetric reason or the fetal reason, we'll do cesarean section rather than, vaginal delivery is the preferred method if they are well stable. And cardiac and BP monitoring, contraception, that's all discussed or looked after during postpartum time. They also get a detailed contraception counseling because not all the methods are suitable for them. So this is at the nutshell. I wanted to talk to you about the pregnancy. Sorry. As you can see the last slide, I don't know how much, it's quite a little bit crowded, but in the postnatally, we discussed the future CVD risk. So there'll be counseling regarding weight loss, physical activity, exercise, smoking cessation, cholesterol monitoring, blood pressure control. If they got urine protein, that needs to be followed up. Fasting, if they're diabetics, fasting glucose needs to be assessed. And we also discussed them that for future pregnancy, when they become pregnant or they're planning, they can start the low dose aspirin. And then if they have diabetic, then diabetes needs to be quite strictly controlled before they become pregnant or they contemplating another pregnancy. So there'll be, and during postpartum period, there is aggressive blood pressure control to monitor the aortic dissection, evaluate the heart function, evaluate the valve function. So basically postpartum time, we take the opportunity to educate them, to stabilize them. And so they can then go for a contraception. And then this is the time they will understand that what is the risk for them for the future pregnancy, what are the risks for how the pregnancy will complicate their cardiac status or their health in general. Thank you very much for listening. Thank you.
Thank you. Thank you, Dr. Rehana Madam, for your wonderful presentation. It is actually a very evidence-based presentation and very much crystal clear because you mentioned elaborately regarding the changes in pregnancy and also the effect during pregnancy and how we preconceptionally up to the delivery and after postpartum period, we will manage this sort of patient. May I now request Professor Farnadhan, Madam, the Honorable Chairperson of this session. Madam, please put to your thoughts regarding the presentation of Dr. Rehana, and also what's your thinking regarding the establishment of multidisciplinary team approaches to manage this sort of cases in our country? Professor Farnadon, madam, please.
First of all, I'd like to thank Dr. Rehana. She's a very good friend of mine, and also for a brilliant, brilliant presentation. It was so smooth and so easy to understand. I think that everybody understood her presentation very well. Well, regarding the heart disease in pregnancy, cardiac disease in pregnancy, it is common. That if we compare the heart disease of UK and in Bangladesh, I think the main difference is that there are a number of differences I am perceiving at this moment. First is people, nearly maybe 50% of people and women with cardiac disease are not coming to us. Rest are coming, number one. Number two, even those who are coming to the doctors, they may come late. But as Dr. Rehana has already mentioned, that congenital heart disease is apparent nowadays more, and the ratio between rheumatic and congenital heart disease is decreasing, and that is the picture in Bangladesh as well. So when women come to us, might be they don't go to the cardiologist, to come to the obstetrician first. Sometimes we see them, and I have experience of seeing women with heart disease, like you mentioned in the grade 4, when the woman was refused to take the pregnancy, she took it, and then they take it, and then they go to we have to manage them in any case. So that is also the picture in our country. People are keen to take pregnancy, even if it is at the cost of their life. So you have very nicely mentioned, Dr. Rehana has very nicely mentioned categorically, specifically in which WHO criteria, in which WHO group, that is 2 or 3 or whatever, where they will be presenting and how they will be managed. And what I picked up from your presentation was the best thing, most important thing, I think, was counseling. Because women, patient and her husband should know how they should be counseled, and what is the situation, what they're facing, what is the future for them, and what they should do. Because at the end of the day, everybody cares of everybody is aware, conscious of the baby inside, and how they can take care of the baby. And lastly, I would like to mention that in Bangladesh, we don't have a hospital as such where cardiac disease in pregnancy will be managed, but we have our public and private hospitals where we have all the discipline doctors are there, the anesthetist is there, the medical specialist is there, the cardiologist is there, and the obstetrician is there. So everybody, usually they manage these women together, and when the woman is in labor, of course the whole team is there to manage the woman and take care of her. So I think that this is in Bangladesh, and of course it is coming up. And I would like to mention one thing, that Rehana has very nicely given the protocol, which, Sharmin, I think we can replicate in our country, and we can just hang the protocol and make people aware and disseminate it in the big hospitals. And we make sure, like we have our clinical management protocols, this can be added. We don't have the protocols for the medical diseases in pregnancy. We were planning to do it. So this can be one start where we can add this as a cardiac disease in pregnancy. It can be a starting, and other medical diseases can follow. Thank you very much.
Thank you,
Thank you,
Professor.
Paranapa. I really appreciate that you like the presentation. I will be more than happy, and I think the MDT team we got here, if you need any help, bringing in the picture of in Bangladesh, how you can implement these guidelines, or how you can develop your own, depending on what facilities you got. Thank you.
Can I suggest one thing, Sharmin? Like,
Yes,
we are planning to have this program in, I think, May or March.
No, February.
Conference we are planning to have. There we can have
February.
a sort of, if possible, we can have a sort of this sort of panel discussion where we can discuss how things can be taken from your country to Bangladesh and establishing it like that in our country. I think this can be a sort of panel discussion in which we can discuss. Thank you very much.
Thank you. We keeping a note for that, Charming and myself. Thank you.
Thank you, Farhana Madam. Your talk is always guidance for us. And this is very important regarding the bridging and to reduce the bridging gap of the knowledge in between who are stay in the abroad and in Bangladesh. So in collaboration, we can make a very fantastic guideline to manage this sort of patient in our country. Now, this is the time of very exciting panel discussion. The panel discussion will be moderated by Dr. Mashrafi Ahmed. Dr. Mashrafi Ahmed is one of the brilliant cardiologists, and Bangladesh is always missing you, Dr. Mashrafi. And he is the clinical assistant professor, University of Massachusetts, interventional cardiologist, Pioneer Valley Cardiology Associated. Dr. Mashrafi, this is the time for you. And would you please briefly introduce the honorable panelists of this session also? Dr. Mashrafi, please.
Thank you. Thank you, Charmaine. Thank you so much for introducing me. I'll just say I'm a cardiologist, not a brilliant one, probably. Anyway, thank you for this, this combined session. And আমরা আসলে এই সেশনের প্রথমে আলাপ করছিলাম, ইনিশিয়াল একটা ডিসকাশন ছিল যে how to make it easy access for cardiologists as well as gynecologists to come together. কিভাবে আমরা একসাথে আসলে পেশেন্ট ম্যানেজ করতে পারি যখন দরকার, এবং কয়েকটা পয়েন্ট আসলে আমরা বোধহয় নিজেরা একটু আলাপ করছিলাম যে বাংলাদেশে একটা এস্টাবলিশড যদি একটি গাইডলাইন তৈরি করা যায় বা আমরা যদি সবাই মিলে ডিসকাস করে একটা গাইডলাইন এস্টাবলিশ করতে পারি, তাহলে বোধহয় গাইনোকোলজিস্ট অ্যাজ ওয়েল অ্যাজ কার্ডিওলজিস্টদের জন্য একটু ইজিয়ার হবে যে ওকে, শুধু শুধু ঢাকায় না, মানে এমন একটা গাইডলাইন আসলে বোধহয় আমরা যদি প্রোভাইড করতে পারি যেগুলো ঢাকার বাইরে রুরাল এরিয়াস গুলোতেও কিছুটা হলেও করা সম্ভব, যদিও অনেক সময় অনেক কিছু সম্ভব হয় না। তো সেটি একটি ব্যাপার যেটা রেহানা আপা এবং আমি এর আগে একবার কথা বলেছিলাম যে we can work together to sort of create a suitable guideline. There are guidelines in USA, there are guidelines in UK and Europe. They may not be fully implemented in Bangladesh perspective. What we can implement in Bangladesh perspective in practical point, that is probably most important. And then second thing is the communication between two different subspecialty. As Monwar bhai bolchilen je jokhon ekti gynecological বা obstetric case উনার NICVT তে যায়, উনার সমস্যা হয় হচ্ছে who is going to manage the gynecology and has to transfer this patient out at the end. On the other hand, Nasrin আপা যেটা বলছিলেন যে cardiology service and gynecology service are two different premises. It's difficult to establish a care there. So in that perspective, we are going to talk about few cases. It's like a pre-existing cardiac conditions and pregnancy. এখানে আমাদের অনেক পার্টিসিপেন্ট আছেন এবং পার্টিসিপেন্টদের কাছ থেকে কিছু কোশ্চেন এসেছে। আমার সবার প্রতি রিকোয়েস্ট থাকবে যে সবাই you can ask questions directly. আপনারা সবাই কোশ্চেন ask করতে পারেন, অথবা আপনারা যদি চ্যাট বক্সে কোশ্চেন রাখেন, we will try to answer them as much as possible. I will just introduce my three panelists.
Mashrafi bhai, আমি just একটু include করি একটা জিনিস. Our immediate past Secretary General of OGSB, our society, Professor Gulshan Arab, also joined with us. So in discussion, if you need, you can also include her in your discussion.
Sure, thank you. Welcome, madam. And Farhana Jan, madam, thank you so much for being with us. আমি আপনাকে আমার 5th year and internship সময় দিয়েছিলাম ঢাকা মেডিকেল কলেজে। Thank you for your all the guidance and teaching. আপনাকে আজকে এখানে পেয়ে আসলে আমি খুবই এক্সাইটেড আর কি। তো আমি ইন্ট্রোডিউস করে দিচ্ছি আমার তিনজন প্যানেলিস্ট, ডক্টর মনোয়ার ইসলাম, অ্যাসোসিয়েট প্রফেসর and head of the Department of Non-Invasive Cardiology, NICVD. মনোয়ার ভাইকে আমি অনেকদিন থেকে চিনি, one of the most esteemed cardiologists that I know in Bangladesh, very, very knowledgeable person in cardiology. We have Dr. Shahila Nasreen, Associate Professor and Consultant for Ibrahim Cardiac Hospital and Research Institute. And then definitely Dr. Shirajum Munira, Assistant Professor of Medicine and Cardiology Division of Cardiology, Department of Medicine from Icahn School of Medicine, Mount Sinai, New York. We have 3 established, very well reputed and renowned cardiologists. And I would like to ask Sharmin to may go ahead with the cases, and definitely our panelists will join the discussion how to integrate the care.
আপনি কি শুরু করবেন মাশরাফি ভাই এটা?
আমি
Yes,
শুরু করব।
করবেন।
আচ্ছা, আমি করছি তাহলে।
জি।
First case, case 1, a primary patient at 22 weeks of pregnancy with history of congenital cardiac conditions, PDA, which is already repaired. What will be the next plan for her in case of non-repaired PDA cases in pregnancy? What is your advice for her? Put some light on ASD and pregnancy conditions. So literally আসলে প্রথম কেসটি হচ্ছে যদি কারো existing cardiac congenital cardiac condition থাকে, PDA, ASD, অথবা আমাদের এই চ্যাট বক্সে একটা কোশ্চেন এসেছিল যে tetralogy of Fallot যদি থাকে, তাহলে আমাদের আসলে কি করা উচিত? It may be repaired or it may be non-repaired. So I would like Dr. Shahila Nasrin Appa to first put some light on this sort of scenarios where congenital conditions may pose us some, difficult question. How we are going to manage pregnancies or advise young female who want to be pregnant in near future with this sort of conditions. What we should do as a cardiologist and what OB team should do in this sort of perspective. আপনার unmute করতে হবে।
Thank you, Dr. Mashrafi. It's a nice question. First of all, where is the question?
So
আমি দিয়েছি,
Where
আবার
is the
দিচ্ছি।
question?
জি।
Oh, thank you. Okay. It's a primary patient at her 22 weeks of pregnancy with PDA. PDA, usually it depends on the size. If it's a small or moderate size of PDA, it doesn't creates any problem during the pregnancy and the delivery process. And if it's a large one, usually it manifests at early childhood, and there's every chance that the patient will undergo repair. So if it's a repaired PDA, there is no complication, and the delivery and the whole course of the pregnancy will be like that of a normal person, normal woman. This is number one. Then what will be the next plan for her? Her plan will be like that of usual normal delivery. Then another second question is non-repair PDA cases in pregnancy. I have already mentioned, if it is mild to moderate, there is no harm. She can continue her pregnancy like a normal pregnancy. Only in Bangladesh, we emphasize to initiate antibiotics during delivery period, because it is well known that we have to maintain the hygiene very poorly during the delivery process, and also during the if it is cesarean section, we are already using the antibiotic in our country. So in that case, we don't need to, yeah. Okay. This is sorry. Is there anybody asking any question? Okay, no. Then, so this is for about PDA, and for ASD, again for ASD, if it is small or moderate size ASD, you can carry the pregnancy and the delivery as usual. There is no harm. But if it is large ASD, in that case, the manifestation will be at their early childhood, and commonly they present it after repair. And once this is repaired, ASD, PDA, all are normal like that, a normal pregnancy. So I think there is no big harm to continue pregnancy with repair or mild to moderate like ASD and PDA.
আপা আমাদের বাংলাদেশে কি
So, anybody
কনজেনিটাল
wants to
হার্ট
add
ডিজিজ বা
anything
প্রি
more?
এক্সিস্টিং কন্ডিশন থাকা অবস্থায় ওবি পেশেন্টদের কোনো গাইডলাইন আছে এই মুহূর্তে?
ইউজুয়ালি আমাদের ওরকম কোনো গাইডলাইন নেই বাংলাদেশে আসলে, মানে অবস্ট্রেটিক সাইডে আছে কিনা জানি না। আমরা যেসব পেশেন্ট পাই, ধরেন পিডিএ অল অন এ সাডেন ডায়াগনোসিস ডিউরিং প্রেগনেন্সি, কেন পেশেন্ট জাস্ট শর্টনেস অফ ব্রেথ নিয়ে প্রেজেন্ট করছে। তো শর্টনেস অফ ব্রেথ নিয়ে প্রেজেন্ট করার পরে গাইনোকোলজিস্ট যেটা করতেছেন, আমাদের কাছে একটা একোর জন্য পাঠাচ্ছেন। জাস্ট একো করতে গিয়ে আমরা যেটা পেলাম যে মাইল্ড টু moderate size PDA or ASD. So mild to moderate size PDA or ASD খুব একটা হার্ম করে না। এটা অলমোস্ট লাইক নর্মাল ডেলিভারি। খুব বেশি যেটা হয়, বেশি হলে at the end of the third trimester পেশেন্টের শর্টনেস অফ ব্রেথ একটু বাড়তে পারে, দ্যাটস অল। আর আমরা বাংলাদেশে অলওয়েজ, যদিও এটা যে অ্যাকর্ডিং টু গাইডলাইন ইনফেক্টিভ এন্ডোকার্ডাইটিস প্রোফাইলিক্সিস এর মধ্যে পড়ে না, কিন্তু আমরা তারপরে ইনফেক্টিভ এন্ডোকার্ডাইটিস প্রোফাইলিক্সিস হিসেবে আমরা অলওয়েজ অ্যান্টিবায়োটিকটা এনকারেজ করি।
এবং এই অ্যান্টিবায়োটিকটা আপনারা কোন সময় দিচ্ছেন? এট দ্য টাইম অফ ডেলিভারি এজ আ
Usually
ওয়ান সিঙ্গেল
যেটা
ডোজ অর
যেটা
ইজ ইট
করে
লাইক
একটা
আ
হচ্ছে হাফ এন আওয়ার বিফোর ডেলিভারি, আর আরেকটা আমরা দিতে বলি 6 আওয়ার্স আফটার ডেলিভারি। কিন্তু কমনলি যেটা বাংলাদেশের প্র্যাকটিস দেখি আমরা, যে অলওয়েজ আফটার ডেলিভারি অবস্টেট্রিশিয়ানরা একটা অ্যান্টিবায়োটিক কোর্স দিয়ে দেন, সেটা নর্মাল ডেলিভারিতে দেন, সেটা সিজারিয়ান সেকশনে দেন। সো এটা আমাদের অ্যান্টিবায়োটিক প্রোফাইলিক্সটা কভার করে নেয়।
আর এমনি ইন্টারন্যাশনালি যে গাইডলাইন গুলো আছে বা ইএসসি বা আমেরিকায় আমেরিকান সোসাইটি অফ কার্ডিওলজির, সেগুলো ইমপ্লিমেন্টের ক্ষেত্রে বাংলাদেশে আপনার ডেফিনেটলি ইটস নট ইজি প্রবাবলি, রাইট?
জি।
আচ্ছা, আপনি আর কোনো এই গাইডলাইনের উপরে আর কোনো লাইট আপ করবেন?
আমি এটাতে আর লাইট আপ করতে চাচ্ছি না। যদি আপনাদের সময় থাকে তাহলে আমি একটু আমার কয়েকটা সিনারিও শেয়ার করতে চাই, যেটা আমি হসপিটালে এরকম কিছু পেশেন্ট ফেস করছি, জাস্ট
Sure.
নট এসডি পিডিয়া আদার। তাহলে আমি কি আমার স্ক্রিন শেয়ার করবো?
জি আপা।
ডু ইউ হ্যাভ টাইম?
জি আপা, আপনি শর্টলি করেন। জি।
ওকে, তাহলে আমি জাস্ট শর্টলি করতেছি।
Shafi,
জি আপা।
can I add one line with Dr. Sahila Appa?
জি।
Like before actually she's very right. Like whenever congenital defect is corrected and it's well maintained, the circulation, there is no leftover shunt. In that case, actually almost there is no difference with the pregnancy with a non-congenital person with a pre-existing corrected congenital anomaly. That is very right. And only I want to add one line with that unrepaired PDA and unrepaired ASD. So because unrepaired PDA and ASD, those are actually Dr. Rehana actually explained the whole congenital anomaly and the pregnancy management very in detail and wonderfully. So it actually falls on the category of mild if it is a small PDA or a small ASD. However, it may not be small all the time. If shunt ratio is extremely high, especially PDA gives you left-sided, ventricular left-sided heart dilatation, means we get LV dysfunction. And if ASD is shunt percentage is very high, in that case we get right-sided ventricular RV dilatation and the pulmonary hypertension. So if PD is enough to give you LV dysfunction, in that case it falls into category of that WHO classification of group 3, and the pulmonary hypertension category falls into group 3 as well. It may be, it can fall into the category 4. So in that point, like PD and ASD, like it may, most of the time it might be small. That's why patient came up to this certain lifetime that became a pregnant, like at least more than 20 years old, but it may not be all the time the scenario if patient develop all LV dysfunction or RV dysfunction. So it can fall into category 3 or 4 as well. So that has to keep in mind.
Thank you আপা।
Thank you.
Can I share my screen? I have already shared it. So can I start with the scenario 1?
Sure.
Okay. My scenario 1 is patients with MBR is on tablet warfarin, underwent unplanned pregnancy. So she shifted to enoxaparin in her first trimester, and there is development of ischemic stroke followed by spontaneous abortion. And thereafter, there is also complete recovery without any residual deficit. Second time, she underwent again unplanned pregnancy 2 years later with successful delivery of a healthy baby by LECS. She belongs to modified WHO class 3 with significantly increased risks of maternal mortality of severe morbidity and maternal cardiac event rate of 19 to 27%. So do you want to know how we manage this patient?
So you switch this warfarin to enoxaparin in the
Yeah.
first trimester,
Yeah,
right? Because the warfarin has this sort of in a
teratogenic effect.
higher dosage, particularly
Yeah.
with the teratogenic
Yeah.
effect.
When it is more than 5 milligrams per day.
Right. Now, when did that ischemic stroke happen? Is it on the
Straight
enoxaparin?
Yes, when she was on the enoxaparin in her first trimester.
Unfortunate, huh? She got
I think the compliance has to be questioned.
Yeah,
right.
there is also, of course, because you have to take the enoxaparin 12 hourly, and there is also we in Bangladesh we can't measure the level of anti-activated factor 10. So there is
Right.
also some problem. So all this contributes to her spontaneous abortion. This was her first pregnancy, and the second pregnancy, it was successfully delivered by cesarean section. And at that time, she was also shifted to enoxaparin in her first pregnancy, followed by warfarin in second and third trimester. And as what we are doing in 36 weeks of pregnancy, we have shifted to again low molecular weight heparin. And at 36 hours before the cesarean section, we shifted to unfractionated heparin, and we have stopped it 4 to 6 hours before the delivery. That means LSCS, and we started the unfractionated heparin 4 to 6 hours after cesarean section. This is my scenario 1. So can I shift to my scenario?
রেহান
Sure.
আপা আপনি একটু অ্যাড করেন from ops point of view থেকে রেহান আপা
Yeah, so as you already mentioned that warfarin, if it is low dose, we try to continue with that. But if it is, as you said, if it's high dose, then we try to shift it to enoxaparin. So sometimes it's not easy, but what we do, we teach them how to do that. One thing is good that here in UK we get pre-filled, it's just injection comes in the ready-made doses.
Yeah,
I
this
don't
is
know
also
whether you
available in
get it in Bangladesh.
Yeah, this is also available in Bangladesh, and we also teach them how to push it. Like
Okay,
insulin.
so what actually made her second time successful? Because then she learned how to do it, or she accepted it to have the enoxaparin?
Possibly it was the lesson for her. The first pregnancy was lesson for her. So I think this helps her to continue her second pregnancy and a successful delivery.
And how do you as obstetrician? So if this lady was my patient in second time, what as obstetrician I would have done, because knowing that or এর আগে যে complication হয়েছিল I would encourage ওখান থেকেই মানে যখন ওর miscarriage holo and ischemic stroke holo, then that will be the opportunity to have the counseling. I'm sure you did. Otherwise, second time, I think she was more compliant. So this is how we also try to do, because I know that's a very difficult time. But what we try to do, যখন তারা সাধারণত 6 সপ্তাহ বা এরকম অ্যাবর্শনের পরে we try to bring them back to our clinic and আমরা যেটা করি এটাকে বলি debriefing, we go through the whole thing যে দেখো এই হয়েছিল এই জন্য তোমার মানে এবার next time when you get pregnant you should have aspirin, start aspirin early. When your pregnancy test is positive, you need to tell us. So then we confirm the pregnancy first around 10 to 12 weeks. We will confirm with the dating scan, or we'll do the scan and see what it is. And then we will arrange for her to have another scan, including the fetal echo, to rule out any congenital abnormality for that pregnancy. And for these pregnant ladies also, what we do them like 28 weeks, 32 weeks, 36 weeks. We do growth scans from the obstetric point of view to check whether the baby is growing okay or not. Because mom, when someone is with the heart disease in pregnancy, one of the complication is growth retardation. So you want to make sure the baby is growing okay. And if someone has got other comorbidities, I don't know whether this lady had like say diabetes, then they're even more high risk. And there is no, I don't know why she ended up with a cesarean. Was it her choice?
No, yeah, this was her choice because this is a valuable child. This is her second pregnancy.
Okay.
You know that.
Yeah, I know the culture and things. Yeah, so
Yeah,
she chose
this
to
is-
have a cesarean section. That's fine,
Yeah.
but yeah, that makes sense. And what we do, I think we discussed about the antibiotic prophylaxis. If someone needing antibiotic prophylaxis, we try to, for the cesarean, routinely everyone gets it when before the induction of anesthesia, basically. If they're having spinal, just before that, before we start the cesarean. And if they're in labor, we think they need antibiotic because they are high risk for endocarditis, or they got some other indication, like they got temperature, or we suspecting chorioamnitis. We normally carry on. If they're not allergic to penicillin, we give them benzyl penicillin, and you carry on every 6 hourly. If they're allergic to penicillin, which is very common in Western countries, then we give them either vancomycin, or sometimes they can have cefalexin plus metronidazole 8 hourly. So that we'll do. Now also in the UK, with any instrumental deliveries like forceps or ventouse, we do give 1 dose of antibiotic. And then postnatally, we don't continue with antibiotic unless they have got some other indication. There is like, say, their infection is there, they're having temperature or some other. Normally, we just stop it at the point of delivery. And then after the delivery, if they belongs to group complicated group 2 or 3, or then we keep them in hospital for at least 48 hours. And then when they get discharged, then the community, that's the facility we got here, they goes to the community midwife. But if I was practicing in Bangladesh, what I would say that I like to review them maybe around 72 hours or something like that with a joint cardiologist team or someone I'm practicing with. So that's what I was like to add. Thank you.
Yes, alright. So can I show the scenario 2?
Yeah, thank you. Yeah.
It's not moving. What's happened to it? Just a minute, it's not moving.
স্টপ করে আবার দেন আপা, মুভ করুন।
স্কেপ করে দিব?
স্টপ করে আবার শেয়ারটা দেন, মুভ করুন।
Just a minute. এটা কি স্টপ ভিডিওতে যাব নাকি স্টপ শেয়ারে যাব? Okay, stop sharing.
Stop
share
share
again.
and then start again. Thank you.
Yeah. Okay. Okay. আমি সিনারিও 2 তে না গিয়ে আমি ডাইরেক্ট সিনারিও 3 তে চলে যাচ্ছি। Okay. This is my next scenario. She's a 27 years diabetic, hypertensive, dyslipidemic, positive family history of ischemic heart disease lady with BMI 24, wife of an expatriate, presented with non-STMI. ECG revealed T inversion in one AVL beyond V6 and tropi was raised. Her ejection fraction was preserved and CAG revealed significant LA deletion, underwent stenting, and we instituted antiplatelet statin, bisoprolol, amlodipine, anti-diabetic agent, can't institute ARB or AC inhibitor for hypertension, considering her reproductive age, as she was only 27 years old. She was advised not to become pregnant for 1 year, as it was a case of ACS. But unfortunately, she became pregnant after 1 month, as didn't use contraceptive as her husband wanted another baby. She visited me 4 months after the procedure and continued all this medication throughout the first trimester of pregnancy and gave birth to a stillborn dysmorphic baby by MVD. So this was her angiogram. Look, this was her LAD, which was approximately 90% mid-LAD lesion. And this is after stenting her LAD. So do you want to ask me any question?
So was she type 1 diabetes? Because her BMI is
Yeah.
24, she's 27.
Yeah.
Was
No,
it type
she's
1?
not type 1. No, she's type 2 diabetic. First time she developed diabetes when this was her second pregnancy.
So
She
during
developed diabetes
pregnancy,
during
so
her
she-
first pregnancy, yes.
So
During her
she was
first
GDM.
pregnancy.
Okay, gestational diabetes. Okay.
Initially, it was gestational diabetes, but later she became
She
permanently
became,
diabetic.
okay.
Yeah.
Yeah, it's quite surprising that a 27-year-old lady developed such a lesion.
Mashraf, it doesn't surprise me. Do you know how many biryani houses are there in Bangladesh?
No, this is not.
Whatever
this is not for
biryani scale,
biryani.
it's 27. It's like
It's
She's
as,
27 and
Death.
she's
as proportionate as cardiologist. All my
No,
colleagues
no.
are cardiologists. They are all my classmates.
no, ma'am. She is from village. She's not from
Oh, she's
city.
from village.
Yeah,
Oh, she's not having
city
biryani
dweller.
then.
Oh, yeah.
We ask Monwar sir to comments on this case. Monwar sir, would you please?
Actually, this is also interesting that such a young lady had such acute coronary syndrome during the age of 27. But this is not uncommon in Bangladesh. And you know that like other South Indian, South Asian just races, Bangladeshis are unduly prone to develop ischemic heart disease, coronary artery disease. And the course of coronary artery disease is often more malignant in comparison to the Western people. And maybe they run 10 years ahead of the counterparts. One thing, another thing that I have one thing in my point in my mind that after stenting, AC inhibitor or ARB was not prescribed.
Yeah.
But I think the lady had stenting, and AC inhibitor or ARB has got documented beneficial effect in this.
I know, but
case.
considering her reproductive age,
But you have
I
already
intentionally
prescribed.
didn't.
You have
Yeah.
already prescribed statin. This is also
Yeah.
contraindicated in
But-
case of pregnancy or breastfeeding.
I know,
like
I
these
know,
things.
but she was dyslipidemic lady. I was bound to prescribe it to her. But for hypertension, I can manage it with amlodipine. That's why I started amlodipine instead of AC inhibitor or ARB. But statin, it was absolute indication.
But I think you could
Yeah,
also
but-
prescribe this inhibitor.
Yeah, yeah, I
with
know.
exercising the utmost caution and also very stringent advice for continuing appropriate contraception.
Yeah, we have given it to her, and she's wife of an expatriate. Her husband was not supposed to come at that time, but unfortunately he came at that time, and he's the door of this mishappening of
This is not uncommon actually in Bangladesh, that sometimes the ladies are to choose one of the two, whether to continue the conjugal life or to choose for the restrictions for pregnancy or like these things.
So,
And they-
Manaral Bhai, what
Yes.
my question is, so why we seeing more and more hypercholesteremia in Bangladesh, you're saying, in comparison to other Asian countries? Why? Is it our food? What is it?
This is
What is
also
our
very
risk
interesting.
factors?
It is also very interesting question. I think this is due to two factors. One is the race, the Bangladeshis are unduly prone to development of ischemic heart disease risk factors, also dyslipidemia. And you know that South Asian dyslipidemia is a special entity, and that consists of just high TG, low HDL, and also the LDLs are of smaller configuration. So these people are unduly prone to develop dyslipidemia. And another one may be related to our lifestyle. We are rice-eating people, and also we are very reluctant to physical exercise. All these things may contribute to the high prevalence of dyslipidemia in our people.
So what is you will be like if you want to give us as a Bangladeshi one advice, that one will be like, don't be sedentary, do exercises and don't eat that much of rice and do some activities. But do you think people should have, after certain age, they should have aspirin? Do you think aspirin has got roles?
This is also another important question. At present, the evidence does not support the use of prophylactic aspirin randomly.
Ma'am,
Probably it will not
can
help.
can I add here a point? There was 3 studies, aspirin, SN, and another one. Monomer, do you remember? There are 3 studies. One is SN, another is aspirin, and another one, and I forgot the name. So there is no definite role of aspirin unless you have ACS, or that means acute coronary syndrome, or CCS, chronic coronary syndrome. There is no role of aspirin.
So
we are
what
not
advice
using,
you will give to the Bangladeshi population that eat less rice and do exercises? So how can they prevent their risk factors? How can they prevent it happening to them?
yeah, like she's a diabetic patient. So first of all, she has to control her diabetes properly. This is number 1. Number 2, we have to change our dietary habit. Like rice doesn't impact on this. Rice only increase the level of TG, not the LDL one. So the main culprit is the LDL one, not the TG. So when we control the diabetes, the dyslipidemia will also spontaneously correct it, and we have to use the statin to control the dyslipidemia level. And the number third one is we have to do regular physical exercise. It's also exerts an important point. Then we can take fish oil, sea fish oil, sea fish, all these. So I think all these factors helps us to maintain the dyslipidemia within a normal range.
Oh, thank you. I think the discussion is very interesting, but I'm quite aware that it's like 11 past 11 and you all have to go to work tomorrow. So we need to, I think, carry on and conclude sometime soon, isn't it? Everyone is almost approaching midnight.
Right, sure. So let's just talk about maybe one more case, Sharmin. Maybe the one is more of the common thing that you and we both sort of experience is probably the hypertension in pregnancy type scenario where, yeah, I think this is a good case. It's a young 21-year-old lady with diabetes and hypertension now planning to become pregnant. What should be the preconceptional counseling for her? Difference in investigation, management, and follow-up of existing medication changes, strategies of pregnancy, induced hypertension, and pre-existing hypertension. I would like to start with Monwar Bhai first, and then I will ask Lopa Appa to put some shade on this. Hypertension managements in and around pregnancy, and if they are already on some medications, how we switch them, how should we tell them what to do and what not to do?
Thank you, Mashrafi. Just can you specify the level of hypertension the lady is having?
So suppose, probably type, hypertension 130s, 140s, but on 2 blood pressure medication like amlodipine and lisinopril.
Okay. So the young lady is unfortunately having hypertension as well as diabetes. So this is a special case. And regarding the definition of hypertension, this lady is having chronic hypertension. On the background of chronic hypertension, he got pregnant, or she is willing to get pregnant.
Right.
So the first thing is that the pregnancy should be better well planned. And if she is already on some drugs, as Dr. Mashrafi has said that she is on amlodipine and ACE inhibitor. So at first, in case of planned pregnancy, she must quit ACE inhibitor. She can continue amlodipine throughout the pregnancy. And I think during the pregnancy, she needs two important things. One is to maintain the blood pressure up to the target level. And there are a lot of controversies regarding the appropriate target level for pregnancy, hypertension in pregnancy. But she could maintain this nearly around 140-90 millimeter mercury. And during this maintenance, she may need to add some other drugs. And in that case, she may take, in addition to amlodipine, labetalol, or sometimes alpha-methyl dopa can be a choice. With this, the target may be maintained, and throughout the pregnancy, she can continue this. And if there is any issue of hypertensive emergency or like these things, in that case, additional medications may need to be added. And nowadays, the recommendation is to use IV labetalol, and also the time-honored hydralazine or other things can be, drugs can be added. The issue is that sometimes we come across some hypertensive ladies who was on ACE inhibitor with or without other drugs and got pregnant. And then what to do? We know that ACE inhibitor and ARB are certainly teratogenic. And so in that case, there is high chance of having fetal abnormality. In that case, there is a dilemma, and fetal monitoring or everything should be done. And if there is any evidence of anomaly, in that case, therapeutic abortion could be the solution. Otherwise, it could be continued. And this is not 100% certain that a person with ACE inhibitor must have teratogenicity. So in that case, careful monitoring is the thing that is needed. Another important point I like to add that traditionally we were taught that during pregnancy, non-dihydropyridines, that is non-dihydropyridine calcium channel blockers like verapamil and diltiazem are contraindicated. But nowadays, there is a paradigm shift, and verapamil has been advocated by the latest WHO guideline for hypertension that it can be prescribed in pregnancy if needed. And the diabetes mellitus should be managed as appropriate. Thank you.
Oh, thank you, Monor Bhai. Lopapa, question to you. So if you see a patient like this, suppose you switched her from, you took off ACE inhibitors, and whether you put it or not to a new medication, how frequently you will sort of monitor these patients for blood pressure? Usually we do not frequently monitor patients for our blood pressure 3-4 months, but for a pregnant lady, how frequently you will monitor that?
Thank you so much, Mashrafi. It's a very nice question. But you know, the setup is different here in US, our practice. So usually the hypertension with pregnancy, there is a different classification, whether it is gestational or not. So cardiologists actually don't monitor the patient routinely. Usually we do for the initial visit, patient comes like pregnant counseling. That time we kind of discontinue the teratogenic medication, as Dr. Manorva said, and we put the new medication if needed for the patient. And then we suggested to do a echocardiogram. Always pre-existing hypertension patient gets a baseline echocardiogram. And then during the pregnancy, every 4 months, we follow the patient to see that whether at least there should be 3 visits in 3 trimesters with the cardiologist I'm talking about. But in between, of course, patients should follow as well as with the obstetrician to monitor, and they usually adjust the medication. But we as a cardiologist see the patient in every trimester if the blood pressure remains controlled with the certain medication. And also, Marshafi, if you don't mind, I have few slides about the hypertension and pregnancy. If I can, if we have 5-6 minutes to discuss about, I would like to do that.
Yeah, I just want to add something from the obstetric point of view for this young lady, because this lady is the perfect example that she would benefit from preconception counseling.
Yes.
And that counseling, it needs to be not only the obstetrician. We also try to include the fetal medicine specialist, so they can elaborate what are the risk of the babies in view of her already diabetes, hypertension, medication, teratogenicity. What are the risk of baby having, the problems, fetal anomalies or growth restriction, or all the complication from diabetes and hypertension. So, and she would have been advised to strictly control her diabetes and high blood pressure, optimize it. And I totally agree with Manor Bhai that when they are two medication, we look at which one is actually highest risk of causing teratogenicity, and stop that one and change to another one like labetalol, methyl-dopa, something like that, rather than stopping both of them, because then it becomes difficult to manage the high blood pressure. So this lady, if she actually had the counseling, we also recommend her to start having the aspirin and folic acid when she started planning for the pregnancy. Once the pregnancy is confirmed around sort of 10 to 12 weeks time, we do call it dating scan. When we know that pregnancy is viable and is in the right place, then we would see them again sort of 16, 17 weeks. And that time they will be in a MDT clinic with the endocrinologist, internal medicine specialist, cardiologist, obstetrician, and everyone. We always also, because these are the ladies, they are actually very high risk for pregnancy, like say preeclampsia and eclampsia, because they've got diabetes, they got high blood pressure. So they need strict monitoring of both the condition. They need regular growth scan. So we normally say 28 weeks growth scan, 32 weeks and 36 weeks. So that's about the monitoring the baby. They will have continuous CTG monitoring. So we've tried to, because if it is diabetes, as is just only diabetes and on medication, we try to not let them go beyond their due date. We try to induce them between 38 to 39 weeks because high risk of stillbirth and other complication. But if she has got diabetes and hypertension both, I think she would be induced between around 38 weeks. But that will be the discussion, and then she agrees or disagrees, with the risk that if she gets induction, it may not work and she may end up cesarean section. So that's one point. And every trimester, around say 16 weeks, we like to do LFT, renal function, everything. And so because, as I said, these are the ladies who are at very high risk for having preeclampsia superimposed on all this existing condition. That's all I wanted to add from my obstetric head. And this is the same thing in the postpartum time. We will counsel her again to plan the pregnancy wisely for the next time. Thank you.
Can I just, Dr. Mashrafi, can I add one thing here?
Would you like to put your slides here as well, Appa?
Mm-hmm. Yes.
Dr. Mashrafi, can I add one thing here?
Sure,
Yes,
sure.
madam.
I think that there was a question also in the chat box. why you said she was an amlodipine and AC inhibitor. Of course, the AC inhibitor will go off, but why not she, because she's not yet pregnant. So she's trying to conceive, planning to conceive. Why cannot we give her switch her onto labetalol in the first place? Oral labetalol, if it is available in your country, because labetalol is very much available in Bangladesh, and we are very much using it and with good results. So labetalol
I
is
think
safe
that-
in pregnancy. It can be started from the beginning, day one.
Yeah, I
Yeah,
think
we
I
are
totally
using
agree with
labetalol also.
Farhan Appa that if we can start the labetalol before even she conceives,
Yeah,
then
yeah.
actually it will be better. Yeah,
I
thank
think
you.
so. Thank you.
Right. No, so that question uses, yes, we can start labetalol at the very whenever we want to, because this is no contraindication. The main
Yes.
part was a discussion about what we should do for existing medication. Should we just let it go and monitor pregnancy, or should we switch
Yeah.
it just to make it easier? So yes,
I would
if we
say
need to
as
switch
patient
this,
already on two medication, in that
Mashrafi.
case, it's better to start stopping ACE inhibitor and start another medication along with the amlodipine. And the best one, of course, the labetalol.
Exactly.
Right.
Yes, in Bangladesh, we are using
using
it very much. And patient in this case, I prefer labetalol to start with.
So it is
Right.
important, Madam, Farhana Madam, that is preconceptional counseling and management of the patient is very
Yeah.
important to switch over this sort of the drugs when the patient is planning for the pregnancy.
Exactly.
Now, Charmaine, I have a question
Yes.
for you. So when we have this sort of scenarios, do you guys follow any particular guideline to, all right, I'm gonna see prenatal visits 3 times, but for this group of patients, I will make it 5 times. How do you guys handle this sort of things?
I think Farhana Madam will give the best answer on it, because OGSB has own guideline and it is disseminated in the root level of our obstetrical care in Bangladesh. Particularly for the medical condition and pregnancy, we don't have the separate guideline, but Madam is planning to do this guideline in her tenure. I think, Madam, you can give the best answer on it.
No,
Madam.
actually, Dr. Mashrafi wants to know whether we have the more number of checkups for these ladies. Of course, we
Yes.
recommend, but in Bangladesh, nothing is so streamlined. But we
Right.
recommend when the woman comes to the first checkup, then we see her more frequently. When women with diabetes come, we have to see them more frequently until they are settled, until the blood sugar is settled and the control is okay. So of course, these pregnant ladies will have more frequent checkups.
Thank you, Appa. So I think Lopa Appa put some slides on the blood pressure, some basic definitions here.
So it will be very short. I will try my best to finish in 5 minutes. As all of us, we know that there is some categories of hypertension during the pregnancy. So one is that our case is mentioning the pre-existing hypertension. If patient comes in first trimester pregnancy, and along with that, we find that blood pressure is high. So in that case, even patient may not be on the medication. Maybe it was not diagnosed, but if it is before 20 weeks of pregnancy, it is actually patient had pre-existing hypertension. It's not that patient developed during the pregnancy. And then if it is after 20 weeks of gestation, we level it as a gestational hypertension. Preeclampsia is the gestational hypertension or pre-existing hypertension along with the proteinuria, which is more than 300 milligram per 24 hours. And whoever has chronic hypertension, they are the more prone to get actually preeclampsia and the complication, and eclampsia defined as a preeclampsia along with the convulsion is the we level as a eclampsia. And those patients should actually usually get like a presenting with the proteinuria, sudden increase in blood pressure, elevated and abnormal liver function, thrombocytopenia, and sudden increase of blood pressure in a patient with previously controlled blood pressure. So that's how we can categorize actually. And I put some slide that what are the common medications safe during the pregnancy. All of us, we know the alpha methyl dopa, which is actually only the PO medication, and the labetalol, as Farhanadar madam was mentioning about nowadays, actually labetalol is the one actually widely used and very safe medication. Though labetalol is available the PO as well as IV, and we can use the nifedipine as well, and the nicardipine. Nifedipine is the PO and nicardipine is the only IV form. And during the hypertensive emergency or the preeclampsia, there is available also nitroprusside IV can be used. Especially nitroprusside IV is used whenever patient with the preeclampsia or severe hypertension along with chest pain or angina symptom. So that is preferred as well. And hydralazine also available PO and IV form. So those are the medication, but I will keep in our practice, actually we'll keep at the top is the labetalol and hydralazine and nifedipine PO. Those are for the routine monitoring. And alpha methyl dopa, it was actually previously it was very widely used. Nowadays, because it's a centrally active medication, not very widely used anymore in our country, like in New York, because lot of patients get actually edema, peripheral edema, and also it is like a patient get in rebound hypotension as well. If patients stop taking the medication, they actually get the rebound hypertension or hypotension. The side effect, because of the centrally acting medication, the side effect is more than the other. All the medication has side effect is more or less. And we already talked about the ACE inhibitor ARB. It is actually completely, it's a class D, FDA class D means it's actually proven already that it is teratogenic, especially the lisinopril is lisinopril, enalapril, and the ACE inhibitor group more than even ARB group. ARB means losartan or angiotensin receptor blocker group is both of them are teratogenic, but ACE inhibitor is more teratogenic than ARB. And they do actually fetal renal dysplasia and oligomenorrhea or oligohydramnios. Oligohydramnios, the amniotic fluid volume goes down and the fetal renal dysplasia. So that's why actually if patient already, baby develop already renal dysplasia, in that case, maybe the indication for termination of pregnancy, but oligomenorrhea gives a lot of other complication as well. And I put my last slide here, like what are the medication cardiovascular? I think this is very important. It's from the FDA and central illustration, cardiovascular medication in pregnancy. So the green portion is actually the safe medication, which is widely used. And the yellow one is like, we can limited data available, but it's certainly been used if needed. And the red one is like completely contraindicated. I always tell my resident and the fellows that at least know the green one and the red one, because the red one, usually I make fun that if you don't know the red one, you may lose your license, because those are like our main purpose is do not harm. So we have to know the red group of medication, which is absolutely contraindicated in the pregnancy. So from the antiarrhythmic, adenosine can be given, metoprolol and the metoprolol group, digoxin, lidocaine. Those are mainly we are talking about here about the hypertension. So I'll emphasize on the hypertension part. Labetalol, nifedipine, or alpha methyl dopa. They are safe in pregnancy, considered as safe, and those are the FDA category of C and B. And other medication like hydralazine, nitroglycerin, nitroprusside, isosorbide, those are like it's a limited data, but it's also been used. Another medication I really want to, because we deal with a lot of heart failure, peripartum cardiomyopathy and heart failure patient as well, furosemide and hydrochlorothiazide. Furosemide is the safest one, means Lasix. The market commercial name is Lasix or furosemide, and hydrochlorothiazide also can be given. Also, another diuretics is very safe during the pregnancy, which is bumetanide. And along with that, as Dr. Shailapa mentioned about the CAD patient, for them, actually, antiplatelets are quite safe. The aspirin, clopidogrel, pasugrel, Brilinta, ticagrelor, And even the thrombolysis can be given. We don't know the enough data, but it's also been used. Then most safest anticoagulation is the unfractionated heparin and the enoxaparin. Those are the group. Fondaparinux also can be used, but main safe one is the unfractionated heparin and the Lovinox or enoxaparin. And a contraindication group of medication is the more important. Besides the beta blocker, actually, labetalol, metoprolol we can use, but not the atenolol. Also, same way, ACE inhibitor ARB. So atenolol, that we have to keep in mind. A lot of time we maybe emphasize all the time ACE inhibitor ARB, but we forget about the atenolol. Atenolol is completely contraindicated along with the spironolactone, statin, and that other novel anticoagulant. Those are contraindicated. So we cannot use those medication. We have to keep in mind also amiodarone, antiarrhythmic drug, also not indicated. And as we talked about other case about how to manage the anticoagulation for the metallic valve patient, because biprosthetic valve does not need the anticoagulation, but the metallic valve need the anticoagulation. So if we need actually warfarin less than 5 milligram all throughout to make, and we can maintain the target INR with a less than 5 milligram of warfarin, we can continue the warfarin throughout the pregnancy. I want to mention it's not necessarily every time in first trimester we have to change it to Lovinox or heparin, because if it is patient requires more than 5 milligram of warfarin, and we can maintain the target INR of 2 to 3 usually, or valve case sometimes higher. In that case, we can continue the warfarin throughout the pregnancy. That is, I want to say, mention is that a take-home point, that first we have to think about whether really at all we need to change it to Lovinox or warfarin or not. If we are unable to, in that case only, in first trimester only for the first trimester, we need to switch it to low molecular unfractionated heparin or the enoxaparin. And second and third trimester, we can do actually warfarin. Only during peripartum period, we have to switch it to unfractionated heparin. Another thing, if we are planning to give, if we are not able to maintain the INR first trimester with the coumadin or warfarin, and we are planning to give the enoxaparin or low molecular with heparin, we have to follow the level of the factor 8. If we are not able to maintain the level of the factor 10A, factor 10A is the suggestive of that Lovinox is working properly for that patient. If we are unable to check the case Dr. Shailapa was mentioning, that in Bangladesh we cannot do the factor 10A level. In that scenario, it is only recommended from ACC and HA guideline to use the heparin, not the low molecular with heparin. Thank you.
Thank you. Thank you for the details about all the hypertension and medication. That was very useful. Thank you.
You're welcome.
All right, so quickly discuss, I know it's quite late. I'm just quickly ask maybe Dr. Monor Bhai, patient with rheumatic mitral valve disease, any advice to them if they have already have the mitral valve replaced, or if they have some sort of rheumatic mitral valve disease but not replaced, how would you advise them to proceed to their pregnancy?
And Mashrafi, I'm sorry to interrupt. I really have to leave and take my daughter to the swimming class. It was my pleasure to be here, and thank you so much. And Farhan Dewan, madam, I was your intern. Most likely you don't remember me. I was with Dr. Anwara, madam, and your unit in DMC during my internship, K51. So I'm very delighted to see you here and join as a faculty in this program along with you. And thank you, Dr. Rehana and Dr. Shalapa and all other Mashrafi. Thank you so much.
Thank you, Munira. Thank you. Thank you for your participation. It was excellent to have you. Enjoy rest of the day. Enjoy the swimming. Bye.
Thank you.
Bye,
Thank you,
thank
Dr.
you.
Mashrafi. This is also a common scenario in Bangladesh. Here are two important issues. The lady may be a known case of pneumatic mitral valve disease, and now she is going to get pregnant. In that case, this is a planned pregnancy. And before getting pregnant, the rheumatic heart disease should be adequately managed according to the guideline. As a general rule, mitral stenosis is not tolerated well during pregnancy. And if the valve area is more than 1.5, then it is categorized in 3. And if less than, then it is 4. So rheumatic mitral stenosis is a notorious condition for pregnancy. And in that case, before pregnancy, the lady should go to the cardiologists, and the rheumatic mitral stenosis should be treated as per the guideline, like she may have PTMC or valve replacement according to the indication. Now come to the point that if sometimes, and we also come across some cases that the rheumatic mitral stenosis is being diagnosed during pregnancy for the first time. And in that case, we are helpless. There is a dilemma whether he or she, whether the lady should be allowed to continue pregnancy or should terminate this before getting. If the valve is suitable, then second trimester is the best time for PTMC, and she should have PTMC during the second trimester. And if the valve is not suitable for PTMC, this is a dilemma, and in that case, the pregnancy, if possible, can be maintained with heart team approach and ultimately with close monitoring. And I will go to the details just later on. And if the lady is on a prosthetic mitral valve and now she has got pregnant, what will be the anticoagulation strategy? In that case, prosthetic mitral valve, I assume that this is a metallic prosthesis. This is a high risk condition for getting thrombosis. And in that case, proper anticoagulation is a must. If the requirement is up to 5 milligram warfarin per day, this can be continued, keeping the INR at the optimum level between 2 and 3. If the requirement of this warfarin exceeds 5 milligram per day, in that case, this should be switched to low molecular weight heparin like enoxaparin and or just unfractionated heparin. One thing is important, that in case of long-term use of unfractionated heparin or enoxaparin, osteoporosis prophylaxis should be given as well. If the patient is on warfarin during the second and third trimester, just up to the 36 weeks, and before 7 days, this should be switched to unfractionated heparin or low molecular weight heparin. If unfractionated heparin, this can be continued just up to 6 hours before delivery. And if this is not, that is then the treatment is low molecular weight heparin, then before 6 hours of delivery, it should be switched to unfractionated heparin, and then ultimately just before the time of delivery, 6 hours before the time of delivery, it should be stopped, and then delivery should be continued, performed. The recommendation is to perform normal vaginal delivery in most of the cases, except in critical cases like acute pulmonary edema, or if the situation is very unstable. In that case, just cesarean section can be performed. And after completion of the delivery, in case of normal vaginal delivery, after 6 hours, again unfractionated heparin should be started, and then it will be followed by low molecular weight heparin and then warfarin before discharge from the hospital. This is the anticoagulation treatment strategy.
Now, most of these patients are young. So are you still concerned about osteoporosis and treat them concomitantly?
Yes, because in case of anticoagulation in pregnancy by heparin or low molecular heparin, it has to be given months together. And so, though the risk is not very high, but still, and just osteoporosis prophylaxis is recommended. Most of the ladies in Bangladesh already get osteoporosis prophylaxis to some extent in the form of vitamin D and calcium supplementation, and that could be augmented during that period.
All righty. Thank you, Monwar Bhai. Anyone has any questions from OB team to my cardiology team that how we can help you guys to facilitate the smooth and safe pregnancy?
Sorry, just I want to add one point here. Vitamin D cannot be used during pregnancy or during lactation. We can use calcium. Vitamin D is contraindicated during pregnancy and lactation. But we are giving in the form of cholecalciferol. This is contraindicated.
No. We actually give vitamin D in pregnancy. It's not contraindicated. We prescribe them. Vitamin D is not contraindicated. The problem in Bangladesh is, even though it's very sunny, people are not exposed. They are covered up, or they are not going in the sun. They uses too much of sunscreen and all this thing, and also covering up. But vitamin D is not contraindicated in pregnancy. So people who are from Asian background, we actually give them vitamin D, prescribe them.
Can I make a comment regarding these women? We get a lot of young pregnant ladies who come with, we find that they have heart disease, and many, in my practice, I have seen, in my clinical tenure, I have seen that women who are already PTMC is done, they behave very well. There's no problem during pregnancy, during labor, and they just behave like a normal normal pregnant lady. So, and the cardiologists here are really, they do their job well, I think that. And when the patients, I'm again repeating, sometimes the patients don't come at all. So when the women come to the doctor, it is treated, and the treatment is very, very good. I think that the PTMC, when it is successful, the pregnancy is all right. It's good. Thank you.
So the oral vitamin D is acceptable. You shouldn't go more than 4,000 international unit. But what we do, we give them 1,000 like that once daily. So oral dose, you don't give intramuscular or anything. So vitamin D is not contraindicated. So all the Asian population in this country, and especially if someone, they wears hijab and they don't go out that much, we give them folic acid, vitamin D regularly. So it's not contraindicated. Thank you. So I think what I gathered, we had a very fruitful discussion. And I think we saw in the chat box and the groups as well, there's lots of enthusiasm to develop some sort of guideline and sort of see within the Bangladeshi, whatever exists in there, the facilities. I don't think there is any lack of skilled personnel. All the cardiologists are there, obstetricians are there. It's like how to, so basically all the ingredients there and how to cook it, how to make a dish. So that's all needed to be done. So I think we can all come together and then make something. It's not going to be a guideline which we're following in NHS, England, or in America. It will be something which will be particularly to follow in Bangladesh. But it was excellent contribution from the cardiology team. Thank you very much for your contribution. I'm very aware that it's quite late, so I think we should conclude. But we're going to carry on this. So this one was the existing cardiac condition in pregnancy. But then I think we're going to carry on for the acute situation, what we do, and all these things in the next couple of months' time, maybe in September sometimes, because there is some session coming up already for one is in pregnancy related and one is hypertensive. So I think After that, we can have another session jointly with the cardiology team. It was very excellent contribution from the cardiology team. I really enjoyed it as obstetrician.
Thank you, Appa. Thank
Thank
you,
you.
Monwar Bhai. Thank you, Shaila Appa. And most of all, thank you, Farhana Madam, for
Thank you
being
all.
with us pretty late in Bangladesh. I would like to request Sharmin to finish it up.
Thank you.
If you have
I
any.
just want to know whether this Samina madam wanted to make any comments because she's here, but I haven't heard from her. Samina madam? Samina madam, can you hear me?
হ্যাঁ হ্যাঁ শুনতে পাচ্ছি ওই আমার এক আত্মীয় তার প্লেটলেট কমে গেছে একবার 9,000 হয়েছে তার ডেঙ্গু বিভাগ চলছে তার সাথে একটু কমিউনিকেট করছিলাম আবার একটু 1.5 ঘন্টা পরেই আবার ওটা 18,000-এ উঠে গেছে আচ্ছা কি কি বলছিল বলো সরি আমি শুনতে পাচ্ছি না কেন হ্যালো
Have you got any
হ্যাঁ,
comments? আপনি কোনো comments আছে সামিনা ম্যাডাম?
কমেন্টস যেমন আমি এনজয় করেছি খুব তোমার প্রেজেন্টেশন ইট ওয়াজ ভেরি এভিডেন্স বেসড একটা প্রেজেন্টেশন এবং এত সহজে আমরা আমাদের সকলের কাছে ক্লিয়ারলি মেসেজটা গেছে আর এটা ঠিক যে মাস্টারটি খুব সুন্দর করে যে পরিচালনা করেছে এবং আমি সিরাজুল মনিরা ওরও প্রেজেন্টেশনটা আমার কাছে খুবই ভালো লেগেছে যেটুকু ও দেখিয়েছে আমার মনে দ্যাট ইজ যে কোনটা গ্রিন এবং কোনটা রেড ড্রাগ সেটা আমার মনে হয় আমাদের সকলের কাছে থাকা উচিত সেটা একটা আমার কাছে ভালো লেগেছে আর একটা হলো যে লাস্টে যে অবস্টেটিক ম্যানেজমেন্ট এবং কার্ডিওলজিস্টের ভিউ থেকে আমার কাছে মনে হয় যে সেটা আমাদের জন্য খুবই প্রয়োজন এবং এর সাথে আমি যেটা মনে করছি যেটা প্রথম থেকে আমরা চিন্তা করছি এবং ফারহানা ওটা নিশ্চয়ই করবে যে কার্ডিয়াক ডিজিজ ইন প্রেগন্যান্সির একটা আমরা প্রোটোকল এবং এটা লো রিসোর্স সেটিং এর জন্য যেরকম প্রয়োজন সেরকম আমরা করব খুব মানে যেমন ধরো আমরা থানা হেলথ কমপ্লেক্সেও যদি আমরা এই ধরনের কেস ম্যানেজ করতে পারি ডিস্ট্রিক্ট লেভেলে ম্যানেজ করতে পারি সেইভাবে আমাদের প্রোটোকলটা যদি আমরা করতে পারি দ্যাট উইল বি গুড এনাফ ফর আস তো এক্সিলেন্ট যে তোমরা এত সুন্দর প্রেজেন্টেশন এবং টাইম দিয়েছো এর জন্য সকলকে ধন্যবাদ জানাচ্ছি আর একটা তোমরা তো আসবে ফেব্রুয়ারিতে হ্যাঁ তো ফেব্রুয়ারিতে প্রোগ্রাম গুলো একটু আগে ভালো করে আমরা যদি রিশাফল করে নিই যে কি কি আমরা করবো সেটা আমার মনে হয় যে সেইভাবে প্রোগ্রামটা করাটা দরকার তুমি একটা বোধহয় রাফ একটা স্কেচ করেছো তারপরে একটু আমরা একটু দেখতে চাই হ্যাঁ
ঠিক আছে ম্যাডাম আপনাদের আমরা তো আপনাদের কাছ থেকেই জানতে চাই যে আপনারা কি চান এন্ড সেইভাবে আমরা সো ফারহানা ম্যাডাম আপনি তারপরে আর সবাই সিনিয়ররা যারা আছেন আপনারা আমাদেরকে যদি একটু গাইড করেন what will be beneficial then we can plan accordingly
আচ্ছা একটা কথা আমি বলি আমরা এইটার বিষয়ে আরেকদিন আমরা একটু জুমে বসবো এটা করার আগে তাহলে আমাদের মনে প্ল্যানিংটা ভালো হবে
হ্যাঁ আমি শারমিনকে রিকোয়েস্ট করব এটা একটু মানে কোঅর্ডিনেট করার জন্য ঠিক আছে শারমিন থ্যাংক ইউ
ম্যাডাম আমরা একদম শেষ দিকে আছি একদম সময়ের পাল্লাতে আমি ফারহানা ম্যাডামকে বলবো যে একটু র্যাপ আপ দ্য সেশন ম্যাডাম আজকের সেশনটা যদি আপনি র্যাপ করেন এবং এরপরে একটা ছোট্ট কুইজ আছে যেটার জন্য খুব এক্সাইটিং হচ্ছে আমাদের গিফটের ব্যবস্থা আছে সেটা 1 মিনিটে আমি শেষ করব ফারহানা ম্যাডাম প্লিজ
Thank you, Dr. Sharmin. I think it was really a very excellent session. It is 12 a.m., nearly just 12 a.m. in Bangladesh, and I have been up maybe 6 a.m. in the morning, still going on. So actually, it was so exciting, especially I loved the presentation of Rihanna. It was so comprehensive. And then going on to the case scenarios. I missed the first case, but I was in the second 2 cases. I think case scenarios are very good for reshuffling your brain and thinking and coming up with solutions. And of course, interacting like people, somebody says one thing, somebody adds, and then everybody is benefited. So thank you everybody for being here and for very interactive session. Thank you, Sharmin, for giving me this opportunity. And I think Dr. Manwar, Dr. Mashrafi, of course, Rehana, Dr. Shahila, everybody contributed a lot. Thank you so much.
Thank you.
Thank you, madam.
madam.
Thank you very
Thank
much.
you, everyone. Thank you, Mashrafi. Thank you, Manwar Bhai. Thank you,
Welcome, welcome.
Sharmin. Thank you, Sahila. Thank you. Take
You're
care.
welcome.
Bye.
Our next OBGYN session is 18th August, and it will be on vaginal birth after cesarean section. Professor Narendra Malhotra, he is the eminent speaker, and he will talk on this topic. So we will give the details of the program very soon to all of you. আপা একটা আমাদের কুইজ ছিল, উই ক্যান স্টার্ট দ্য কুইজ। কুইজের অ্যান্সারটা যারা দিবেন তারা চ্যাট বক্সে অ্যান্সারটা লিখে দিবেন। সবার আগে যিনি অ্যান্সার করবেন তিনি আসলে আমাদের এক্সাইটিং প্রাইজটা পাবেন। সো চ্যাট বক্সে আপনি অ্যান্সারটা রাখতে পারবেন। ফার্স্ট কোয়েশ্চেন হচ্ছে, প্রেগন্যান্সি ইজ অ্যাবসলিউটলি কন্ট্রাইন্ডিকেটেড ইন দ্য ফলোইং কনজেনিটাল ডায়াগনোসিস। কোনটাকে আপনারা মনে করেন যেখানে অ্যাবসলিউটলি কন্ট্রাইন্ডিকেটেড? সাইনোটিক ডিজিজ, ফন্টেন সার্কুলেশন, Eisen-Menger syndrome, TGA with systemic right ventricular or left ventricular dysfunction. আমার মনে হয় আমরা অ্যান্সারটা পেয়ে গেলাম। সবার আগে সাদ্দাম তিনি অ্যান্সার করেছেন। সো তমা আমরা যদি একটু পুট ডাউন করে নেই তাহলে আমরা নিতে পারবো ওনাদের কাছ থেকে। সাদ্দাম হোসেন কারেক্ট অ্যান্সারটা দিয়েছেন সবার আগে। নেক্সট কোয়েশ্চেন, আমি আর এক্সপ্লেনেশনে যাচ্ছি না আজকে, কারণ এটা আমাদের সময় নেই হাতে। Second question, a woman with aortic coarctation visited the outpatient clinic for pre-pregnancy counseling. She asks whether there is any chance to go for the baby any congenital heart disease. The recurrence risk ta koto percent? Answer kore felun je korben. আমরা একটু সেকেন্ডটা দেখি কি অবস্থা। এটা হচ্ছে 4% হচ্ছে এটার অ্যান্সার। এটাকে দিয়েছেন মাইনুল হাসান এন্ড সাদ্দাম হোসেন, দুজনেই একসাথে দিয়েছেন। তমা একটু আপনি নোট করবেন ওনাদের কাছে যেন আমরা পৌঁছে দিতে পারি। ওনাদের ইমেল অ্যাড্রেসটা রেখে আপনি যোগাযোগ করে নেবেন। থার্ড কোয়েশ্চেনটা আমরা যদি আসি, পেরিফেরাল ভাস্কুলার রেসিস্ট্যান্স নিয়ে যে কোয়েশ্চেনটা আছে, ডিউরিং প্রেগন্যান্সি ডিক্রিজ করে কত পার্সেন্ট? Correct answer is 30 to 40%. So আমাদেরকে রাইট আনসার কেউই তো দিলেন না, এটা আমরা রাইট আনসার পেলাম না কারো কাছে। নেক্সট আমরা যাই, আমাদের নেক্সট কোয়েশ্চেন হচ্ছে, a patient with normal aortic diameter and vascular Danel's contaminated pregnancy, what WHO classification should she be in? Correct answer is WHO classification 4. So the correct answer ke dilen কেউই দিল না আমার কাছে মনে হয়। তাহলে লাস্ট কোয়েশ্চেনটা আমরা যাচ্ছি। A woman present with the first trimester of pregnancy will having a mild impairment of the left ventricular function but feeling otherwise well. Which of the following drugs is not contraindicated in the first trimester of pregnancy? Dr. Mainul, Dr. Imran Hossain, Dr. Saddam Hossain, তিনজন একসাথে দিয়ে দিয়েছে কারেক্ট অ্যান্সার। তো আমার কাছে মনে হয় এটা আমরা এখন শেষ করছি। যারা বেস্ট অ্যান্সার দিয়েছেন তাদের কাছে আপনাদের গিফট পৌঁছে যাবে। থ্যাংক ইউ ভেরি মাচ। আজকে সবাইকে আমি মনোয়ার স্যারকে এক্সট্রা থ্যাঙ্কস জানাই যে স্যারের ব্যস্ততার মধ্যে স্যার এত লম্বা সময় ধরে আমাদের সময় দিয়েছেন। থ্যাংক ইউ রেহানা আপা, আপনার প্রেজেন্টেশনটা একটা গাইডলাইন ছিল আমাদের জন্য। ডক্টর মাশরাফি, আপনাকে অনেক থ্যাঙ্কস, হসপিটাল থেকে জয়েন করে প্রায় 2 ঘন্টার মতো সময় দিয়েছেন। থ্যাংক ইউ ভেরি মাচ। আমরা আজকে
Thank you,
Thank you,
everyone.
Shabir.
Thank you.
Thank
Thank
you.
you,
দেখতে পাচ্ছি
Fatima
প্রফেসর
Ashrafi
ফাতেমা
Appa.
আশরাফ
Thank you.
ম্যাডামকে এখন দেখতে পাচ্ছি। ম্যাডাম এতক্ষণ দেখতে পাইনি। ম্যাডাম আপনাকেও থ্যাঙ্কস, আপনি ছিলেন প্রথম থেকে আমাদের আজকের আয়োজনে। থ্যাংক ইউ ম্যাডাম।
আপনাদের আরেকজন
Thank
বোধহয়
you,
আছেন,
Mashrafi.
রুকসানা
Thank you,
ম্যাডাম।
Moinul Bhai. Thank you. Take care.
Thank
Assalamu
you,
alaikum.
madam.
আসসালামু আলাইকুম।
আমরা আশা করছি সবাইকে 18 তারিখ সেশনটায় পাবো বিজুয়ান ভিব্যাক সেশনটা ডক্টর নরেন্দ্র মালহোত্রা বলবেন। আমার ধারণা অতি খুবই ভালো একটি সেশন হবে সবার জন্য। থ্যাংক ইউ।